gastroesophageal reflux disease. So this is gastroesophageal reflux disease. Now, I told you, normally in most of us, the lower esophageal sphincter is in a state of tonic contraction. And because it is contracted, it does not allow the material from the stomach to come up into the esophagus or reflux up. So what are the factors which maintain the patency of the lower esophageal sphincter? So what are the factors which help in maintaining patency of lower esophageal sphincter and they prevent reflux? In other ways, these are the factors which are going to prevent reflux. So we know this is the lower end of the esophagus, this is the stomach, this is the diaphragm, right? This is the diaphragm, and I want you to know that the esophagus, there is certain portion of the esophagus which is intra-abdominal, So this is the intra-abdominal portion of the esophagus, and this intra-abdominal length of the esophagus is 3 to 5 centimeters. And this intra-abdominal length is the most important factor. This is the most important factor which helps in maintaining the patency of the lower esophageal sphincter. This you need to remember, because if there is adequate length of the intra-abdominal esophagus, this is the GE junction. This purple one is the GE junction. Most important factor which helps in maintaining the patency of the lower esophageal sphincter. This you need to remember, because if there is adequate length of the intra-abdominal esophagus, this is the GE junction. This purple one is the GE junction. So if the intra-abdominal length is adequate, it will keep the GE junction intra-abdominal and it will prevent reflux. But if this length of the intra-abdominal esophagus, this is the GE junction, this purple one is the GE junction. So if the intra-abdominal length is adequate, it will keep the GE junction intra-abdominal and it will prevent reflux. But if this length reduces, then this GE junction will open up and stomach acid will start coming up. So please remember this is the most important factor. Factor number 2. Reflux. But adequate length of intra-abdominal length is the most important factor. This is the most important factor which helps in maintaining the patency of the lower esophageal sphincter. This you need to remember, because if there is adequate length of the intra-abdominal esophagus, this is the GE junction. This purple one is the GE junction. So if the intra-abdominal length is adequate, it will keep the GE junction intra-abdominal and it will prevent reflux. But adequate length of the intra-abdominal esophagus, this is the GE junction. This purple one is the GE junction. So if the intra-abdominal length is adequate, it will keep the GE junction intra-abdominal and it will prevent reflux. But if this length reduces, then this GE junction will open up and stomach acid will start coming up. So please remember this is the most quick. It will keep the GE junction intra-abdominal and it will prevent reflux. But if this length reduces, then this GE junction will open up and stomach acid will start coming up. So please remember this. This is the most important factor. Factor number two. Factor number two is the angle of his. So factor number two is the angle of his. Angle of his is the gastroesophageal angle. Angle of his is the GE angle. So most important factor was length of intra-abdominal esophagus. The second factor is the GE angle, gastroesophageal angle. The third factor is the pinching effect of the diaphragm. Right, the third is pinching effect of diaphragmatic crura. Pinching effect of diaphragmatic crura. This keeps the lower esophageal sphincter contracted. Right, so right, the third and the fourth factor is that of diaphragmatic crura. Pinching effect of diaphragmatic crura. This keeps the lower esophageal sphincter contracted. Right, so diaphragm will have a pinching effect. And the fourth factor is arrangement of mucosal folds. Is arrangement of mucosal folds. But this arrangement of mucosal folds has least contribution in maintaining the patency of the lower esophageal sphincter. So please remember the most important factor is the length of the intra-abdominal esophagus. And if the length of the intra-abdominal esophagus, if the length becomes less than equal to 2 centimeters and the lower esophageal sphincter pressure becomes less than 6 millimeters of mercury, this is when GERD will start occurring. This is when GERD will start occurring. And when GERD occurs, what is happening? Is the sphincter relaxing too frequently or it's not relaxing? Correct, it is relaxing too frequently. So in GERD, what happens? There is increased TLOSR. What is TLOSR? You will read this term. TLOSR is increase in the number of transient lower esophageal sphincter, transient lower esophageal sphincter relaxations. Okay. So increase in the number of transient lower esophageal sphincter relaxation is a sign that GERD is occurring. So when you see people burping quite a lot, right, that is a transient lower esophageal sphincter relaxation. Now, these are some new points in the latest edition of Bailey that increase in GERD has been attributed to an increase in obesity and declining rates of H. pylori. I want you to remember that H. pylori, which can cause gastritis, but it is preventive for GERD. It is preventive for GERD. Central obesity is a risk factor which is increasing GERD, and with GERD, Barrett's esophagus and cancer risk is also increased. This we will cover in some time. I will tell you about this in some time. Now, what are the clinical features of GERD? Now, GERD is so common that if you're an MBBS student or an intern, and if you're having your mess food in a government hospital or a private hospital as well, mess food is never good. It is so spicy, it is so oily that invariably you develop GERD. At least once you would have experienced these symptoms. The most common symptom is retrosternal burning sensation, also known as heartburn. It's not the heartburn when you get matched with the wrong person on a dating app. That's not the heartburn which I'm talking about. This is burning sensation behind the sternum. Then you can have water brash. Sometimes if you eat spicy food or if you get acid coming up, you get this such bitter taste in your oral cavity, right? And you feel like choking kind of a sensation that is known as water brash. Then, because of recurrent GERD, patients can have pharyngitis, laryngitis, their voice can change, they can have dental caries, they can get up at night or they get up in the morning and they have a bad taste, a bitter taste in the oral cavity. So, all these features and chronic cough, these are all the clinical features of GERD which you should know about. Now you need to understand that GERD is so common that if a patient with classical symptoms of GERD goes to any doctor or a gastroenterologist, they straight away will not do investigations, right? What they will do is that they will start the patient on empirical treatment for GERD. And only if the empirical treatment is not working or the symptoms are progressing, then only investigations would be done. Now, what are the investigations which are done? And there are 2 points. I wanted to be crystal clear about these 2 points because they've been asked multiple times in the exam. Now, one is investigation of choice and the other one is gold standard investigation. And often students get confused between the two. The investigation of choice is an upper GI endoscopy. This endoscopy will show us that the lower end of the esophagus is inflamed because of acid reflux. So this is the investigation of choice. Whereas the gold standard investigation, and I've told you gold standard is one which will tell you the diagnosis 100% times, but it might not be the most feasible investigation to do. Okay? So the gold standard investigation is 24-hour pH monitoring. Now this will give you the diagnosis 100% times, but we are only doing this if endoscopy is inconclusive, or if intervention is planned. If we know the patient has GERD and we are planning a surgery, then before the surgery we do a 24-hour pH monitoring. Okay? Now 24-hour pH monitoring, the pH probe, if intervention is planned, if we know the patient has GERD and we are planning a surgery, then before the surgery we do a 24-hour pH monitoring. Okay? Now 24-hour pH monitoring, the pH probe is kept 5 centimeters proximal to GE junction. Okay? 5 centimeters proximal to GE junction, and in these patients we should stop PPIs. What is PPIs? Dr. Ranjan must have taught you proton pump inhibitor, right? This is one medicine which all doctors must have consumed at least once during their career, and this is one medicine for which doctors are always chasing medical representatives for samples. So we stop PPIs 5 to 10 days before the procedure to get accurate results, because if you do the procedure on PPIs, then you will not get the representative findings. Now when this 24-hour pH monitoring is done, we calculate the Demister score. The Demister score is calculated, and if the Demister score is more than 14.72, then this is indicative of GERD. Okay, it is indicative of GERD. So this is regarding the investigations which are done in these patients. Now, like I said, most of the time these patients are started on empirical treatment without any investigations. So whenever a patient comes with GERD, you tell them that there are certain lifestyle changes you need to make. Number one, the lifestyle changes, you tell them to reduce weight. Why? Because I told you obesity is an independent risk factor for GERD. So if you are overweight, you will have more chances of GERD. And as the patient loses weight, GERD also reduces. I've seen this in many of my breast cancer patients. Okay, so weight reduction. Then very important is we tell them to avoid food items which relax the lower esophageal sphincter, because if the sphincter relaxes more, there will be more GERD. So what are these food items? These food items are fried food, fatty food, citrus fruits, chocolates, mint. right? So fried, fatty, spicy food, chocolates, mint, all these things you have to tell the patient to avoid. So essentially everything what is available in your college canteen is out. So there is a very restricted number of items which these patients can eat. Then we tell them to take small frequent meals, because if they take a heavy meal, more chances of reflux happening. So we tell them to take small frequent meals, and we tell them that the dinner should be taken at least dinner should be at least 2 to 3 hours prior to sleeping. So the reason of this is that when you lie down, there is more chances of reflux happening, which is why the meal should be taken at least 2 to 3 hours before the person goes off to sleep. Now, sometimes the elders in your homes will tell you that if you're having reflux, put an extra pillow. And that was written in old textbooks. But the latest textbooks say that by adding one pillow, you are not reducing the incidence of GERD. So these are the lifestyle changes. In addition to this, medications can be given to these patients as well. The medications which can be given are proton pump inhibitors, prokinetic agents. Prokinetic agents can be given, and antacids can be given, right? Antacids can be given. So these are the medications which can be used in these patients as well. Now, some of these patients will not respond to the treatment. Majority will. Majority don't require surgery, but some of them will not respond to the treatment, or they will have complications, or they would want to stop the medications, and these would be the patients who would require surgery. So the indications for surgery are patient not responding to medical management, patients suffering from complications of GERD. Complications of GERD, we are going to talk about Barrett's esophagus, which is a very important complication. There can be a stricture which can develop. There can be adenocarcinoma which can develop, right? Adenocarcinoma which can develop. Some patients can have a hiatal hernia. Hiatal hernia covered in the other esophagus modules. A sliding hiatal hernia can be associated with GERD, and these patients will also not respond to medical management and would require surgery. And finally, you have a patient who's well controlled on medicines. So this patient was well controlled on PPIs, but somebody told him that long-term PPIs can give rise to cancer or can cause complications. So the patient now wants to leave his medicines. So if he leaves the medicines, the symptoms are going to come back. So the only way to control it is with surgery. Long associated with GERD, and these patients will also not respond to medical management and would require surgery. And finally, you have a patient who's well controlled on medicines. So this patient was well controlled on PPIs, but somebody told him that long-term PPIs can give rise to cancer or can cause complications. So the patient now wants to leave his medicines. So if he leaves the medicines, the symptoms are going to come back. So the only way to control it is with surgery. So these are the indications when surgery has to be done in these patients. And the surgery which is done is known as fundoplication. So fundoplication is the surgery which we carry out. And what are the principles of fundoplication? I'll just demonstrate to you, and then I'll show you an operative video as well. So we know that the normal intra-abdominal length, I told you, was 3 to 5 centimeters for the esophagus. Now, if the intra-abdominal length reduces, means it becomes less than 2 centimeters, then GERD occurs. So the first point in fundoplication is to restore adequate intra-abdominal length. Minimum 3 centimeters length we need to restore here. Minimum 3 centimeters length we need to get here. Then we need to tighten the diaphragmatic crura so that the esophagus doesn't move up again. Then what we have to do is we take the minimum 3 centimeters length we need to restore here. Minimum 3 centimeters length we need to get here. Then we need to tighten the diaphragmatic crura so that the esophagus doesn't move up again. Then what we have to do is we take the fundus of the stomach. You know the stomach has a fundus. We take the fundus of the stomach, and we are going to wrap the fundus of the stomach we are going to wrap the fundus of the stomach in front of the esophagus, okay, around the esophagus. This is called fundoplication. And the way we wrap the fundus of the stomach, this maneuver is known as shoe shine maneuver. Okay. Now, Ruhani, my daughter has started going to school, and we are teaching her how to shine her shoes, and we've given her a shoe brush, and this is how she shines in the morning. This is how we all used to do it when we were in school. So this is known as the shoe shine maneuver. Now we preserve the vagus nerve and we have to maintain the angle of His, because I told you the angle of His is also responsible for keeping the lower esophageal sphincter patent. Okay, so these are the principles. Let's see a short clip which demonstrates fundoplication, and then I'll tell you about the types of fundoplication. So this is a video of fundoplication, and this was shared by Dr. Pankaj, who is Dr. Sakshi's husband. He's a laparoscopic surgeon. So he had shared this video, and here you can see that first the liver retractor is being put into place so that we can get adequate exposure, and then we are going to start dissecting out the lower half or the abdominal part of the esophagus. So you can see here, this is the attachments are being freed, and we are going to expose the diaphragmatic opening and the lower part of the esophagus. So you can see the attachments are being freed up. So now the attachments are being freed up and we've reached the diaphragmatic hiatus. You can see the cardiac pulsations as well. So this is the diaphragm, and you can see how the diaphragmatic hiatus is being opened up. The lower part of the esophagus is being dissected so that then we can wrap the stomach around it, and we can also tighten the diaphragmatic hiatus again. So you can see the crurae of the diaphragmatic opening which are there, and the esophagus is being freed up. Okay, you can see that with laparoscopy you get a great amount of magnification, and that is one of the advantages of minimally invasive surgery, which I've also highlighted in the minimally invasive surgery module. So you can see here now the esophagus is very well dissected, and then once we've done that, the fundus is going to be mobilized and it is going to be taken all around the esophagus. It's going to be wrapped around the esophagus. So now you can see that the diaphragmatic hiatus is being tightened, and you can tighten this using Prolene suture, so that Prolene suture is in place, and the hiatal opening would be repaired so that again the esophagus does not move up. And we know if the esophagus moves up, then there's going to be reflux again. Okay, and one of the main principles of fundoplication is that we have to bring down the esophagus. We have to recreate the intra-abdominal length of esophagus, right? We have to tighten the hiatal opening, and we have to wrap the fundus around the esophagus. Those are the key steps of fundoplication. So this is the hiatus being tightened, and now you can see that the fundus of the stomach is being wrapped around the esophagus. And before we do this, there is a shoe shine maneuver, and that has been asked multiple times in the exam, that you should easily be able to mobilize the fundus around the esophagus, and this maneuver which you do before you start wrapping the fundus around is known as the shoe shine maneuver. So this, you can see that the fundus is being wrapped around the esophagus. The hiatus has already been tightened, and this will then complete our fundoplication. And we know that we have to minimum achieve a length of 3 centimeters of intra-abdominal esophagus. That is what we want to achieve, minimum 3 centimeters length of the intra-abdominal esophagus. So these are the fundoplication stitches which are being taken, and this is our complete fundoplication which has taken place now, and this is the completed repair at the end. Now the types of fundoplication, you can have complete wrap, that is Nissen's fundoplication, which is a 360-degree wrap. Now complete wrap is when completely you are wrapping the fundus of the stomach. Now sometimes this can be so tight that the most common complication which patients encounter after complete fundoplication is gas bloat syndrome. This has been asked many times in the exam. Gas bloat syndrome is that the fundus has been so tightly wrapped around the stomach that the patient cannot even burp now. right? Cannot even, the gas also cannot come up, cannot burp also. That is known as gas bloat syndrome. And because of this, bloat syndrome is that the fundus has been so tightly wrapped around the stomach that the patient cannot even burp now. Right? Cannot even, the gas also cannot come up, cannot burp. This has been asked many times in the exam. Gas bloat syndrome is that the fundus has been so tightly wrapped around the stomach that the patient cannot even burp now, right? Cannot even, the gas also cannot come up, cannot burp also. That is known as gas bloat syndrome. And because of this, partial wraps have now been started to be done because they will have less chances of this gas bloat syndrome. So partial wrap door is 180-degree anterior wrap, toupee is 180 to 270-degree posterior wrap, and Belsay mark is 270-degree anterior wrap. Now this can be a bit confusing, so I just want you to remember Nissens. Remember the names of the partial wraps, but there is no point remembering the angles because in the last 6 years, I have not seen a single question regarding the angles of partial wraps in any entrance exam. Now, fundoplication, like I showed you, is done in a laparoscopic manner. Nissens was a 360-degree wrap, and toupee is a partial wrap, which I've just shown you. Now, Colles gastroplasty is another surgery which can be done, and this is done when esophageal shortening is there. When esophageal shortening is there. So when there is esophageal shortening, I cannot get adequate intra-abdominal length. So with Colles gastroplasty, I can create a new esophagus. I can create new esophagus out of the stomach, and this is esophageal shortening. I cannot get adequate intra-abdominal length. So with Colles gastroplasty, I can create a new esophagus. I can create new esophagus out of the stomach, and this is by firing a linear stapler. Remember a linear stapler I've shown to you in the sutures module. So you fire a linear stapler along the greater curvature of the stomach, and this is going to create increased length of the esophagus. Neo-esophagus, Colles gastroplasty is done. Now, in the latest Bailey, there are some newer modalities for the management of GERD as well, and I want you to know about this. It's going to create increased length of the esophagus. Neo-esophagus, Colles gastroplasty is done. Now, in the latest Bailey, there are some newer modalities for the management of GERD as well, and I want you to know about this. So one of them is polymer injection around the lower esophageal sphincter so that it keeps it contracted, but this has a high recurrence rate and it is not preferred. Endoscopic radio frequency ablation, this is very important. This has good long-term results. RFA is radio frequency ablation. This I have covered in the module on cautery and blades. Radio frequency ablation has good results here. Lynx device is magnetic sphincter augmentation. So you put magnets around the lower esophageal sphincter so that it keeps it contracted, but this has a high recurrence rate and it is not preferred. Endoscopic radio frequency ablation, this is very important. This has good long-term results. RFA is radio frequency ablation. This I have covered in the module on cautery and blades. Radio frequency ablation has good results here. Lynx device is magnetic sphincter augmentation. So you put magnets around the lower esophageal sphincter and they will keep the sphincter closed. And in the latest edition of Bailey, there is also a transoral incision-less fundoplication. So in laparoscopy, you have to make incisions from outside. But now there are procedures where they're doing a fundoplication from inside while doing endoscopy. And such a procedure is known as a NOTES procedure. NOTES stands for Natural Orifice Transluminal Endoscopic Surgery. Natural Orifice Transluminal Endoscopic Surgery. To know more details about NOTES, you should refer to the module on minimally invasive surgery. In minimally invasive surgery, I've told you about the types of NOTES procedure, so please refer to that module. So this takes care of GERD. We've discussed why it occurs, clinical features, management, investigations, and the surgeries. Now, one of the complications of GERD is Barrett's esophagus, which is extremely important from the point of view of the exam. Now, Barrett's esophagus is metaplasia. Metaplasia is conversion of one epithelium into the other epithelium, and this is also known as specialized intestinal metaplasia. So Barrett's is also known as specialized intestinal metaplasia, and this is metaplasia of squamous epithelium to columnar epithelium. So the squamous epithelium gets converted into squamous epithelium in these patients. And the pathognomic findings, so in Barrett's esophagus, when you see the Barrett's, you get a red velvety mucosa, right? You will see this typical red velvety mucosa is what you're going to see. And the pathognomic finding, if you take a biopsy from this red velvety mucosa, is the presence of goblet cells. That is what is going to clinch the diagnosis in these patients. So if you see the histopathological slide, you will see goblet cells. Goblet cells are these mucin producing cells. These are known as goblet cells, and they will be seen on the esophagus histopathology slide. So you are going to see goblet cells on biopsy. Now, what are the clinical features of Barrett's esophagus? So the clinical features of Barrett's esophagus are same as GERD. The patient will have same clinical features because this is a complication of GERD only. And these would be patients who don't respond to medicines, But Bailey also writes that a lot of GERD and Barrett's patients can have a silent presentation, right? That these patients can have a silent presentation and it is only detected when they are developing complications or cancer. And Barrett's esophagus increases the risk of adenocarcinoma of the esophagus. Not squamous, it increases the risk of adenocarcinoma of the esophagus. Now there are three types of Barrett's esophagus. You can have short segment, long segment, and cardiometaplasia. Now long segment is when the length of the Barrett's is more than 3 centimeters, short segment is less than 3 centimeters, and cardiometaplasia is microscopic Barrett's. Now, if the Barrett's is very well visualized, if it was typical red velvety mucosa like this one, then I know where to take the biopsy from, right? And I will take multiple biopsies. So biopsies, I will tell you later on in the module that they are taken at every 2 centimeters to confirm Barrett's esophagus. So this would be taken from the affected area. But the problem is that you might have cardiometaplasia or microscopic Barrett's. Now this is Barrett's which will not be visualized by the naked eye. So in these patients, to identify abnormal mucosa, we carry out chromoendoscopy. Chromoendoscopy is that we stain the esophagus with the particular dye, and this dye will then highlight to us what is the abnormal area. Now, I'm sure in gynecology, you must have read from Dr. Sakshi that even in the cervix, if you want to find out the abnormal areas, you stain the cervix with acetic acid, and it will give you the aceto-white areas, which are the abnormal areas which you can then biopsy. So similarly, to identify abnormal areas, we can stain the esophagus with Lugol's iodine, which can tell us about squamous epithelium. But for Barrett's and for adenocarcinoma, we use methylene blue. So by staining the esophagus with methylene blue, I will get to know what are the abnormal areas, and then I can take a biopsy from those abnormal areas. So that is how we confirm the diagnosis of Barrett's esophagus. Now, in Barrett's esophagus, there is another update which I want you to know. This is there in the latest edition of Bailey. This is known as the Prague C and M criteria. Prague C and M criteria. So this tells us that we first have to identify the GE junction. Okay, we identify the GE junction during endoscopy. And once the gastroenterologist has identified the GE junction, then they will measure the distance from the GE junction to the maximum point where Barrett's is extending. That is the M value, maximum value from the GE junction. And then they will also see what is the point till there is circumferential involvement of Barrett's. Means Barrett's is involving 360 degrees. That is the C value, circumferential extent. So the significance of this Prague C and M criteria is that higher the C and higher the M values, it denotes that there is more extensive Barrett's and more risk of malignant conversion can be there in these patients. Now, in Barrett's, there is only metaplasia, but if metaplasia, you've read in pathology that if metaplasia is left for a long duration, it can turn into dysplasia, and dysplasia can turn into invasive cancer. So the risk of cancer increases with metaplasia to dysplasia to in situ cancer. Now, how do we manage these patients? These patients are managed using the Seattle protocol. So this is the latest Seattle protocol to manage Barrett's esophagus. Now, in Seattle protocol, it is given in great detail in Bailey. I don't want you to get confused. This is the flowchart given. I'm going to simplify it for you. Right, so first thing is that if there is no dysplasia, okay, if there is no dysplasia means there is only metaplasia. So if there is no dysplasia, then we repeat endoscopy and biopsy every 3 to 5 years. 3 to 5 years. That's all you need to remember here. You don't need to remember these details. So if there's no dysplasia, if you do a biopsy and only Barrett's comes, only metaplasia comes, you repeat the endoscopy every 3 to 5 years and take biopsies. Now, if dysplasia comes, right, if there is dysplasia, LGD is low grade dysplasia. So first of all, you need to remember that this dysplasia needs to be confirmed by 2 pathologists. So if there is dysplasia now, you know that there is a higher risk of conversion into cancer. So to reduce that risk, we have to carry out ablation of the mucosa. We have to ablate abnormal mucosa. Ablate means we have to destroy that abnormal mucosa. How do we destroy that abnormal mucosa? We use radiofrequency ablation. So this Seattle biopsy protocol, I've told you that we will do 4 quadrant biopsies every 2 centimeters, and we will do targeted biopsies of visible lesions. That is how we are going to monitor Barrett's esophagus. RFA, radiofrequency ablation, is the most popular way of ablating abnormal mucosa. It is cost effective and the side effective profile is also better for these patients. EMR can be done. EMR is endoscopic mucosal resection. Endoscopic mucosal resection or multiband technique can be done to remove the whole mucosa, but this EMR technique has high rate of stricture. Endoscopic ablation can be done in flat lesions. So please remember that RFA is the best modality to ablate this abnormal mucosa. So let's come back to this table. Now, if there is low grade dysplasia, you are going to ablate the mucosa using RFA. Now, because there was dysplasia, will you do endoscopies every 3 to 5 years, or would you like to do them at a more frequent interval to see if any change is occurring or not. Of course, you would do them more frequently, right? You want to see if there's any change occurring. So that is why 6 monthly endoscopies are done. 6 monthly endoscopies are done till two negative biopsy results come. Means two biopsy results show that there is no longer any dysplasia. Till then you keep on doing 6 monthly endoscopies, and then you shift to till two negative biopsy results come. Means two biopsy results show that there is no longer any dysplasia. Till then you keep on doing 6 monthly endoscopies, and then you shift to 3 to 5 yearly. Now, if there is high grade dysplasia, or there is cancer, then again ablate the abnormal mucosa. You discuss in the MDT. MDT stands for multidisciplinary team meeting. You discuss with the surgeon, with the gastroenterologist, with the oncologist, and you now take a plan for surgery. What surgery will you do? Esophagectomy. Right, so to summarize for everyone, no dysplasia, continue 3 to 5 yearly biopsies and endoscopy. Dysplasia, low grade, ablate the mucosa, keep on doing 6 monthly endoscopies till you get two negative results. Means two consecutive biopsies show that there is no dysplasia. Then you move to 3 to 5 years. If there is high grade dysplasia or T1 cancer, confirm, discuss in a MDT, and do esophagectomy. That is how we manage Barrett's esophagus, and this is the Seattle protocol to manage Barrett's esophagus, where I told you that biopsies were being done at every 2 centimeters. Now, all the topics which I have covered in this module are also been asked as short notes in your college exams, and multiple MCQs have been asked from all of them. So before I end this module, I want to discuss this very interesting image which I saw while reading a book, and it is so relevant for anything we do in life or any exam which we are preparing for. So for any exam, to crack any exam, you have a not tactics with